to today's Research Roundtable, where we will have presentations by the remaining students in cohort 5 of our RWJF Future Nursing Scholars Program. So I will ask them to make their presentations in alphabetical order. And so first up, we have Carolina Gustafson, who will be presenting her research topic.
Great, let me just get my screen pulled up here and we should be good to go. Let's see. All right. Now we gotta go over here. Slideshow, presenter review. And then we gotta make this work so that you guys are not looking at the wrong thing. Oh boy, let's see. There we go. Alrighty, so you guys should be able to see my slides now. Alrighty, so hi, welcome everyone. My name is Carolina Gustafson and I am in my 3rd year of the PhD program here at the School of Nursing, and I am a Robert Wood Johnson Future of Nursing Scholar. And today I will be presenting my current research on the end-of-life care of young adult solid organ transplant recipients. So some of the background of this topic. So it's important to understand that palliative care, and especially early palliative care, so palliative care prior to when someone is actively dying, is underutilized for both young adults and in solid organ transplantation, and specifically within the scope of this project for young adult solid organ transplant recipients. And it's also important to note, sort of when talking about this topic, that there really is no clear definition in the literature for what a young adult is. And young adults are often lumped in with adolescents, which I'll talk about why that is problematic in a moment. But it really leads to a lack of clarity when people talk about the care given to young adults, since there is no standardized definition of what that term really means. And so much of the research and clinical focuses in solid organ transplant historically have been primarily focused on post-transplant survival. And of the limited palliative care research in solid organ transplant, almost all of that research has been focused on both transplant candidates and older adults. So not on children and young adults, and not on transplant recipients. And so a lot of this belief or attitudes around palliative care within organ transplant comes from this reality that in order for a patient to receive a transplant, it requires a high amount of resources, a lot of time, a lot of energy, and there's a limited number of organs available for transplant. So once a patient has a transplant, often the attitude exists that we don't want to waste that organ if the patient was to die, quote unquote, prematurely. And there's also not the culture of palliative care in solid organ transplant that exists in other chronic illness populations, such as within oncology or heart failure. And so that culture of early intervention with palliative care does not exist to the same extent in solid organ transplant. But solid organ transplant recipients continue to have a high symptom burden post-transplant. They're at risk for a number of life-limiting and life-altering complications. They have very intensive medical regimens they have to follow. They continue to have advanced care planning needs, and particularly for young adults, there are a number of familial needs in supporting family of the patient that exist. And so for these reasons, palliative care really does remain relevant for patients post-transplant. And particularly thinking about young adults, it's important to note that palliative care exists in the unique context of young adulthood, which is an inherent period of transition where patients' insurance status, financial independence, their family relationships, and their support system relationships can all be changing and very rapidly. And so patients who are needing palliative care in young adulthood often have, it's important to consider those sort of unique context of their potential situation when providing that palliative care. And so it's also important thinking about the relevance of young adulthood to solid organ transplant recipients. So it's important to note that about 18% of solid organ transplant recipients are under the age of 35 at the time of transplant. And for comparison, about 3.5% of people with a new oncology diagnosis were under the age of 35. So as you can see, there's quite a substantial number of solid organ transplant recipients who fall within this young adult category. And it's also important to note that a patient who receives their transplant earlier in life, so either in childhood or young adulthood, is more likely to eventually face the realities of repeated organ failure, either due to chronic or acute rejection, which would require that they would need either a new transplant or end-of-life care. So it's important, especially, to consider the needs of young adults when thinking about solid organ transplant and palliative care. And so a large component of my research also aims to examine inequalities in care provided. And so a majority of the previous ethics literature on transplant has focused on ethical concerns around donation and issues that arise pre-transplant, but there's been minimal focus on inequalities or ethical failures that might exist post-transplant. And it's also important to consider from an ethics standpoint the inherent inequalities in solid organ transplant in the state of Georgia. So in Georgia, about 60.1% of young adults awaiting a solid organ transplant are Black, while 26.8% of the same population are white. And for comparison, nationwide, about 27.6% of young adults awaiting a solid organ transplant are Black, and 34.2% of the same population is white. And then within Georgia, amongst young adult solid organ transplant recipients, about 44.8% of young adult solid organ transplant recipients are Black, while 48.5% of the same population is white. And so as you'll see, Georgia has a quite a bit higher rate of young adults who are Black who are awaiting a solid organ transplant. And then if you look at the patients who are receiving organs within Georgia, while more Black young adults are waiting, more white young adults are receiving those organs. So that inherently leads to the belief that there may be some inequalities already present in the system. So an overview of my specific dissertation project. So I will be completing a 3-paper dissertation. The first paper will be an integrative review of how the term young adult is operationalized in the chronic illness literature. The second paper, which is the main paper of the dissertation, will be an analysis of end-of-life care received by 2 cohorts of deceased young adults with chronic illness treated at Emory Healthcare who either did or did not receive a solid organ transplant. And the third paper will describe any disparities in end-of-life care noted and develop strategies for improving care moving forward. And so thinking here, you'll see my specific aims, and in the nature of time, I will not harp on these, but you can see these are the specific aims for that second main paper that I was describing. And so the approach for that main analysis that I had mentioned, so there, as I mentioned, it will be electronic medical record review of Emory Healthcare records, and that data is sourced from the Emory Clinical Data Warehouse, which comprises data from 4 hospitals within the Emory Healthcare system. So that's Emory University Hospital, Emory University Hospital Midtown, Emory Johns Creek Hospital, and Emory St. Joseph's Hospital. And within the parameters of this study, it's important to note that Emory University Hospital has the only lung transplant center in Georgia. So you'll see the dates from which this data was extracted. So January 1st, 2000 to December 31st, 2019. And the year 2020 was excluded due to COVID and the fact that the transplant population and the chronic illness population were a high-risk group in that pandemic. So it felt important to remove that factor. For the purposes of this study, young adult will be defined using the oncology definition, which is 18 to 39. And so this study is made up of 2 young adult cohorts, patients who have a history of a solid organ transplant, and then a chronically ill control cohort that will be crudely matched to the transplant cohort, which are patients with no history of transplant, and they do have a history of malignant neoplasm, heart disease, or HIV. And these conditions were chosen because they are the top 3 disease-related causes of death for young adults per the CDC during the timeframe of this study. And 90 days of care, the last 90 days of life for care was chosen because this is typically the period when the intensity of end-of-life care increases, and there's a precedence for this in the literature. And then it's important to note that the non-transplant cohort will serve to examine care provided to chronically ill young adults who died without the factor of having received a solid organ transplant and the potential bias against allowing for early palliative care that I'm hypothesizing may occur due to this factor. And so some accomplishments and updates over the last year from when I last presented my research at this in this setting. So I actually successfully defended my dissertation proposal last Friday, which was very exciting. And I've spent the last year taking additional coursework in quantitative analysis, big data, and R. I'll also be doing an ethics practicum this summer at CHOA, which will directly impact the ethics components of my dissertation study. I also had an integrative review on the state of the science of palliative care and solid organ transplant published. And then I had some unique career development opportunities over the course of the last semester. I did an 18-week course through the NIH and Emory for PhD students and postdocs in the sciences, which helped to build skills of resilience and receiving feedback, those sorts of things. So that's been really helpful for me internally. And then I also, through my RWJ, I had the opportunity through the Center for Data Science to do 16 weeks of mentored career coaching, which was also a great opportunity to build some of those long-term career skills in academia and the sciences. Here you'll see my dissertation committee made up of Dr. Mikyung Song, Dr. Vicky Hertzberg, Dr. Jeannie Simiati, and they are all from the School of Nursing, obviously, and then Dr. Gerard Vong from the Center for Ethics, and Shela Chaudhra, who's the nurse practitioner in the green shirt, and she serves as a clinical consultant on my dissertation committee and provides invaluable resources and insight into the clinical components of my research. And now I'll open it up for questions or any feedback anyone may have. Thanks so much.
That was fabulous, Carolina. Just great. So good to see your progress and how you moved ahead so much since we had you in 710. I just had a question about when you use the term solid organ transplant, is there a difference by type of organ, or is that worth looking at?
So do you mean what is the definition of solid organ transplant, or specifically within my study, will I be looking at differences?
Well, I guess both are questions, but I was thinking of the second question is why I asked.
Yeah, so within my study, and just for anyone who's not familiar, solid organ transplant just refers to organs, so not a bone marrow transplant, essentially. But within my study, I will be looking, I'm hoping to look by organ to see if there's differences. That is one of the factors that I'm incorporating.
I know the people in the renal transplant area have done a lot of work looking at disparities in Georgia. And so I was thinking that might be worth looking at kidneys just to see what, if it's different for young adults than adults.
Yeah,
it's their focus.
Absolutely.
Great job.
Thank you.
Other questions or comments for Carolina? Kathy, you're muted if you're talking.
No, I asked my question. I think.
Okay, your box just lit up. What's keeping you up at night, Carolina?
I think just trying to finish everything and graduate at some point, and all the different routes I could take. I know Vicky's on my committee, so she's familiar with all the discussion we had, but there's a lot of different potentials. I think I'm lucky that this is very rich data set, but that also leads to a lot of possibilities. And then I think anytime you're working with someone else's data, at least for me, there's always the anxiety of, what is actually in the data and what you're going to find or what you may or may not have access to. So those are my biggest concerns right now.
All right. Okay. Well, thank you very much. And next we will go to Daniel Smith, who will be defending his dissertation in just a couple weeks. So get a sneak peek here.
All right, thank you everyone. So today I will be giving you a sneak peek into my dissertation defense, which occurs May 19th, so 2 weeks from tomorrow at 10 a.m. My talk today is titled The Road from the AMSN to PhD, Learning to Love the Kidneys. So a little bit about the background. Our society is designed to depend on the power differentials that maintain the need for migrant workers. There are many examples of this, including years in the past in which there have not been enough migrant workers and crops have rotted in the fields when native workers refuse to work in the conditions that many farm workers are subjected to. The occupational environment that farm workers work in is only made worse by increasing global temperatures. If you are not aware, the last 5 years have been the hottest on record in the modern era. However, the impact of increasing global temperatures is not limited to farm workers. All outdoor occupation groups are susceptible to the impacts of a warming climate. One example of climate change's impacts on health has been seen through the epidemic of chronic kidney disease of unknown etiology that has been described in Central America. CKDU, as it's also known as, develops whenever persons develop kidney disease in the absence of traditional risk factors, such as diabetes, hypertension, a strong familial genetic linkage, or advanced age. And the disease has primarily been found in young men that work on sugarcane farms. There are many etiological hypotheses for the cause of CKDU, but the leading is that the disease is thought to be caused by recurrent dehydration, which leads to acute kidney injury over work shifts, and ultimately chronic kidney disease and end-stage kidney disease develops. Furthermore, there has been slight evidence for the disease in the United States, and I'll talk about this on the next slide. The association between occupational heat exposure and acute kidney injury has been found in farm workers in both California and Florida. So since our team was already working with farm workers in Florida, I wanted to look at the occupational histories of those who had already developed kidney disease. In order to do so, I partnered with Grady Health, which is Atlanta's county hospital and provides care to many undocumented individuals. Since Georgia is a state that hasn't expanded Medicaid, undocumented individuals with end-stage kidney disease are relegated to receiving dialysis through the emergency department once every week to a week and a half, which is associated with both higher costs and increased morbidity and mortality. Grady, however, has developed a program that provides frequent emergent dialysis to the undocumented population. So they're able to get their dialysis once every 2 to 3 times a week. Not every 2 to 3 weeks, I'm sorry, but every 2 to 3 times a week. And this means less cost. So this program, frequent dialysis, thrice weekly dialysis, cost about $77,000 per year per person, whereas the emergency dialysis that only occurs every week to week and a half costs $250,000 per year per person. And of course, there are better outcomes when you're being dialyzed 3 times a week. So to start off my project, and I'll close my little slide here, I'm sorry, I did a scoping review and I wanted to look at the associations of acute kidney injury and occupational heat exposure in farm workers and what work had been done in the literature. So we went through a process with Sharon of searching PubMed, Embase, CNOL, and Web of Science, and we ultimately had 4 studies that were included, 4 quantitative studies that looked at various different measures of heat stress and kidney functioning, as well as 1 qualitative study that was done as an ethnography with farm workers in California. So one of the studies included was Jacqueline Mix, who was a postdoc in with the team, and then 2 pieces of literature from Sally Moyse's lab out in California that provided this evidence that there is an association of acute kidney injury and occupational heat exposure here in the US. So at Grady, I did find that the average age for people that were participated in our study, we interviewed 50 out of the 125 persons receiving dialysis at Grady, and their average age was 45.9 years old. And if you look at the United States renal disease data, the USRDS, the initiation of dialysis treatment nationwide is 62.6 years of age for all races and genders, and it's 58.7 years of age for Latinx persons. So not only is the average age of people who participated in the study lower than the age of initiation, but you can assume that if they're already in our study as getting dialysis, their average age of initiation for dialysis is even lower. We also found, when combining the results of my sociodemographic and health histories with the occupational histories, that 7 persons lacked the traditional risk factors for chronic kidney disease. So they didn't report having diabetes, hypertension, a strong family linkage. There was no history of myocardial infarction, heavy use of nephrotoxic substances. And all 7 of these people were under 45 years old and had worked in some sort of heat-exposed occupation, such as agriculture, landscaping, and construction. So that points to the need for further work to be done outside of the agricultural community and really understanding what are the heat impacts of rural workers, specifically landscapers and construction workers, because there are differences in how heat, environmental heat impacts rural people versus urban people. So thinking of like the urban heat islands, for example. And then we also found that the majority live at or below 200% of the federal poverty line. So we suggested that one of the simple interventions that people working with the emergent dialysis population could do is make sure that there are prompt referrals to social work so that the all resources are being utilized properly. For my occupational histories, I collected a lot of free text data surrounding my occupational histories. And rather than going through and trying to code by hand, since I didn't produce that rich, thick description that is needed for qualitative work, I analyzed my occupational history data using topic modeling. And topic modeling is a form of natural language processing, which identifies underlying themes in the text data. And it is done so by creating a lemmatized corpus in which words are taken back to their stem. For example, you can see construct up here on the top left was brought back from its various parts of speech to the stem. So construction, constructing, constructed were all made construct. Also in a lemmatized corpus, words such as a, an, and the that have no contextual meaning are removed. In order to identify the underlying topics, principal component analysis is conducted on all the possible vectors or themes that are identified in the text. And for this analysis, there were all the various vectors seem to be clustered in 2 groups. Therefore, we created a final algorithm using a K or N of 2. And this left the models as seen above. And then you can see the various words, their importance to the model are represented by beta. So a higher beta, the more important the words are to the topic. And so lastly, these topics were both named outdoor work, which is represented by the topic on the left in orange, and indoor work, which is represented by the topic on the right in blue. And so this has several implications, just because we always think of occupational heat exposure and occupational exposures as being outdoor, but we did find through these topics, we kind of had this latent hypothesis that maybe we do need to be worrying about our indoor workers, and just knowing that there were 2 different groups of workers provides a little bit of evidence that maybe we need to look deeper into our indoor workers especially. We did have, not reported here, but we did have several women who reported working in dry cleaners, and they reported having no air conditioning and remembering it being very hot in the summer. So other than my dissertation, this is what else I've been up to. If you have been around me in any shape or form, by this point, you know that I got a puppy on the right. His name is Coda. He's a little Cocker Spaniel. He's my present to myself for finishing my PhD. I do think that I have found a career that I love, and I'm excited about the next steps in terms of research and being a nurse scientist. In the past year, I've had 4 first author publications. My undergraduate thesis, it was kind of this paper that would never die, but it was published in Environmental Science and Technology. I published my work in Moultrie from 2 summers ago in Workplace Health and Safety, and I look forward to going back to Moultrie in June to continue our research that we started 2 summers ago that were thwarted by COVID last year. I published an analysis of tweets utilizing the keywords heat, illness, and health. So we did a social media analysis using various natural language processing techniques in the Journal of Nursing Scholarship. And then I published my health outcomes paper in the Journal of Public Health Nursing. I also had a Cannes Symposium of Distinction with Dr. Lisa Thompson, Vicki Hertzberg, and Dr. Roxana Chicas in September. I passed my certified nurse educator exam. I do like to teach, and so I was able to be certified as a nurse educator. And I have also finished all but 3 of my APRN courses, which I'm pretty proud of. So my timeline, on May 19th, I will have my dissertation defense. After that, this summer, I plan on writing. We have to write a manuscript as part of my nurse practitioner program with Dr. Phyllis Wright, and I've analyzed the Behavioral Risk Factor Surveillance Survey, which is a nationally weighted survey from the CDC. I've been working on a systematic review with Dr. Lisa Thompson that aims to identify interventions conducted in rural America to mitigate climate change's impact on health. And then with my collaborators at the Clarkston Community Health Center, we are writing a manuscript on providers' perceptions of point of care testing in the clinic. I'm also on the job hunt. I have a job interview on June 4th for an assistant professorship at Case Western School of Medicine. So fingers crossed, all the good karma you can send my way, I would appreciate it. I've also submitted 2 abstracts to the Association of Public Health of the American Public Health Association for their conference in fall 2021. And then this fall, I will still be around Emory, just finishing up one final course for my nurse practitioner program, and then on to whatever 2022 brings me. So what is next? I hope no matter where I end up, I will be submitting a KO1 to the National Institute of Environmental Health Sciences. I'm proposing to use healthcare data and looking at the association of hospitalizations due to new onset acute kidney injury or an acute exacerbation of existing kidney disease and its relationship with heat waves, so particularly in AIM-2, using a time series analysis to do so, and then utilizing AIM-3 to look and see where these people live in urban areas. Are they coming from these urban heat islands that are of particular concern when speaking about urban heat? I am also, as I said, trying to find a job, and will be finishing my nurse practitioner coursework. And then this August, I'm taking a week off and going to my family's mountain home in North Carolina to spend some time on the river and just get away and relax. I would like to say thank you to my dissertation team, which is Dr. Vicky Hertzberg as my chair, and then my committee made up of Dr. Valerie Mack, Laura Plantinga from the School of Medicine, and Dr. Lisa Thompson. I would also like to say thank you to my other collaborators that I have made here at Emory, Dr. Erin Ferranti, with the Farm Worker Family Health Program, Dr. Nicholas Giordano, and Sarah Febres Cordero. We're trying to do some work with training service industry workers on how to administer naloxone to people who have overdosed on opioids, and then Dr. Whitney Wharton for her guidance as I've wrote my first methods paper based on a sero survey we did last spring. And then I would also like to thank Nicole Alexander, who is my student collaborator for the manuscript I'm writing for my nurse practitioner program. All right, thank you all. I will now take any questions.
Questions for Daniel? Lots of clapping, Daniel.
Yes, I see.
So what's keeping you up at night?
I knew you would ask me this, and I never answer it the way that Robert Wood Johnson wants us to answer it, because I think they want us to answer it about our research. I'm really worried about the inaction that even President Biden's team is taking towards mitigating the impact of climate change on health. I feel like we had a lot of promises made that are just not going anywhere. So that is keeping me up at night, and also finding a source of income after I'm done.
All right. Other questions for Daniel?
So this is Sandy. So Daniel, if you could do the study you really wanted to do to change things, what would that be?
My study would be, it would be centered around a community's needs. I would really like to, if I stay at Emory, I would really like to partner with the community in Clarkston and really understand what they envision as being climate change's impacts on their own community, and then working with community collaborators to design an intervention that would allow us to mitigate the impacts of climate change on the community's health.
And what, excuse me, so what might that intervention look like?
So we've had some really interesting thoughts about it as we've been doing this systematic review, and it could be anything in terms of, I see myself as a researcher as more of a facilitator. So if the community said they needed more trees planted, and then they wanted us to determine if the tree shade decrease the temperature of where they're walking. For example, if you're walking down Stone Mountain Path, there are areas that don't have a lot of shade. I would be the facilitator that would facilitate getting the intervention of the trees and then determining, did we decrease the temperature that these people who, Clarkston is a very walkable city, lots of people walk. So are we decreasing the temperatures as people are walking from their homes to the grocery store, for example?
Okay, interesting. Thank you.
Yes.
Other questions for Daniel? Well, with that, we are going to conclude today's research roundtable unless anybody has anything else. All right. Well, thank you very much.
Bye, everyone.